Good morning. Not everyone. Good morning, all of y'all.
Good morning.
Good morning. The weather and the incredible activity on labor and delivery. Who was on last night here?
The 19th is still a big share of us.
Yeah, no, one not after the other. Anyway, it's a great pleasure. I've already extracted about 25 minutes of Dr. So a thing that Canadians find unusual is the American penchant for watching people's names, right? So Dr. Simon's heritage is Hungarian, bouncing to São Paulo, Brazil, some extraordinary training in the nation of Texas, at Dallas, then more training in Quebec, which from many points of view is a separate country. The fact that she was actually born in Canada is mind-altering after all the zigs and zags, and you lived for a time in France, and so you must have a passport that's about 3 inches thick. Anyway, she says, call me Simon, but we all know that it's supposed to be something else. Anyway, it's a great pleasure to continue with our emphasis on development of skills in breastfeeding, to welcome Dr. Simon here this morning to give us some pearls and insights and very interesting information about the benefits. Now, I would just say that we all kind of say, oh yeah, breastfeeding must be excellent. But when it comes to convincing our patients how excellent it is, I think, I've listened to a few people when they didn't know I was listening explain the benefits, and we're pretty rudimentary. And we need to be moving forward with our explanations and the sophisticated information we bring to our patients. So this is another excellent step in that direction for our education. So welcome, Dr. Simon.
Well, I want to thank Dr. Harmon and everybody to have invited me to give this talk. And I hope that, okay, so I have nothing to disclose. And I hope by the end of this talk that I will be able to show you some of the really cool things about breastfeeding. But also, I think we need to recognize when breastfeeding is not going well, or when there are some red flags, and really what we can do about it, and what our role is in really helping, protecting, supporting, and promoting breastfeeding. I will start with, this was an article that was in the newspaper just not too long ago. And the title was, "The more I learn about breastfeeding, the more amazed I am." And honestly, this really resonates with me a lot. And hopefully you will have, I'll let you make your own conclusions by the end of this talk. We know that the AAP supports breastfeeding, supports exclusive breastfeeding for 6 months, and then the continuation of breastfeeding for, I'm sorry, the slides are not coming out very well, but for at least a year. And where WHO and UNICEF recommends for at least 2 years as desired by the mother and the family. And really what's important is that human milk is a normative, is the standard for infant nutrition. And it shouldn't be seen as a lifestyle choice. It's really a healthcare decision that the mother and the society makes. The ACOG also supports breastfeeding. There's a really nice toolkit that was published last year, and it really optimizes the importance of the obstetricians and the OBGYNs in supporting the mother in their breastfeeding practices. Now the Joint Commission also tracks the number of exclusive breastfeeding. So this is something that not only we should do, but it's something that we are actually hospitals are tracking the number of exclusive breastfeeding. It's interesting. It's just important to know that when you look at the exclusive breastfeeding, that supplements with donor milk, it's still exclusive breastfeeding. So it's breast milk feeding. So let's talk a little bit about more of some of the cool stuff. So we know that talking to OBGYNs, I felt that I should start with the fetus. So we know that in utero, the immune system essentially of the fetus is downregulated. And this really is to prevent an immune abortion, to prevent to protect the pregnancy. And we know that at birth, there's a rapid activation of the acute phase response triggered by hypoxia, labor, that really activates part of the immune system. And I'm not an immunologist, so I'm not going to go in a lot of details about this, but we have the immune system is sort of divided into parts. We have the innate, that's the rapid response, that essentially just think about it as physical barriers, chemical barriers, everything that happens at the local level, inflammation. And we know that the babies are born immature in terms of physical barriers. Their skin is their skin and their respiratory and GI tracts, their tight junctions are not sealed very well, and all the changes that this is immature in the newborn infant. Chemical barriers, think about, for instance, the gastric secretion, and so we have the innate immune system, and we have the adaptive immune system, which is really a slow immune system. And what it is, it's antigen mediated, and it really takes a while for the body to make antibodies. So what's interesting is that breast milk really helps develop both the innate system and the adaptive system. And it really targets both the system at multiple levels. We know that the babies start making IgA just at about 4 months of age. So if you think about this, the babies who are formula fed, they really don't have that arm of the immune system for many, many, many months, and they really depend only on the innate system to protect them. This is really cool. I thought it was really interesting as well. So when we talk about the immunoglobulins, we know that the mothers are exposed to an illness or and to bacteria, and then they make antibodies and they transmit it to the children. So they looked at antibodies that were produced for E. coli in mothers in the UK. So they looked at mothers from the UK and their E. coli antibodies, and you can see that they really don't have much because it's not an illness that's really prevalent in the UK nowadays. And they looked at mothers who are in Sri Lanka. That's they really are way more exposed to E. coli than women in England. And you can see that their levels of antibodies in breast milk is really significantly higher. What's really interesting, so now they looked at women who lived in the UK, but they're from Sri Lanka, and they moved from Sri Lanka to the UK many years before they became pregnant. And you can see that these mothers have a reasonable amount of antibodies for E. coli, and this is not recent exposure. So really, there's an immunological memory in the milk that's transmitted to the child. So this child is protected against an infection that the mother was exposed when she was a child. I think this is fascinating. This is another one that I think is really cool. So we know the mother's sick, she makes antibodies, transmits it to the baby. So now the mother's healthy and the babies are sick. And this happens all the time. The babies in the care, they get all the viruses and bacteria that are in the environment. So what's very interesting is that it seems like when the baby breastfeeds, there's a little bit of retrograde flow from the saliva, and a little bit of the saliva goes back into the breast. And there's a local process of making There's a local process of antibody production inside the breast. And within hours, this mother makes antibodies to the baby's illness, and that's transmitted to the milk in the next 2 feedings. I think this is really fascinating. The other thing that I think is really interesting as well is that it seems like there's interaction with the baby saliva and the breast milk itself that really inhibits the growth of some opportunistic bacteria. And just the interaction between the saliva and breast milk inhibits the growth of, for instance, staph and salmonella. There's a lot more than just immunoglobulins in breast milk, and there's more and more that's being discovered every day. I'm going to go over some of them. So we have the immunoglobulins, and we have also some bifidus factors, and these are really cool. So breast milk has some prebiotic effects, and we're going to talk about those. So essentially, they protect the normal flora. And also, they have also some components that really destroy the pathogenic flora. So, for instance, the lactoferrin, it really binds iron. And the pathogenic bacteria, they need iron to proliferate. So if there's no iron, then they can't just survive. And then there are some other components that kill the bacteria by different ways directly. You can see when you compare breast milk, human milk, and bovine milk, that a lot of these factors are present in human milk, and they're not present in formula. All right. So now I want to talk about microbiome, and this is something that has been discovered and been studied fairly recent. And so we know that most internal and external surfaces of our bodies are really colonized by bacteria. It really goes in every single surface that we have. We also know that there's the good bacteria and the bad bacteria. And really, the amount of inflammation in our body is really determined by what bacteria we have in our system. And this really influences a lot of things. A lot of the chronic illnesses now are related to really what bacteria we have in our body. So let's talk a little bit about how the microbiome develops in the infant. So it actually starts in utero. There's data showing that there's some bacteria in meconium of prematures, so it seems like it starts in utero. We know that at birth, it's another step for really important development of the microbiome. The microbiome depends on mode of delivery. That babies who are exposed to who have vaginal delivery, they're exposed to the vaginal flora. They're going to have a different microbiome that babies who are born by C-section. What's interesting is that babies who actually had active labor but were delivered by C-section seem to have a similar microbiome to the babies that were born by vaginal delivery. So it's not just the way of, because initially it was felt it was just a colonization from the skin, but it's more complicated than that. Environment of the newborn, it affects the microbiome as well. If the baby's hospitalized, if the baby lives in an urban environment, rural environment, all of this affects. Antibiotics early in life, of course, affects it, and that really has long-term effects in the child. And the most important that we're going to talk about here is diet, and how diet in the first few months of life, few days of life even, can affect your microbiome for the rest of your life. What breast milk is not just all the components that I talked about, but it's really a personalized medicine. So the mother transmits not only all those prebiotics, probiotics, all those interesting components that we talked about, but she actually transmits some bacteria to the baby via the milk as well. So in a baby who's exclusively breastfed and drinks about 727 around ounces a day, this baby is going to receive about 100,000 to 10 million bacteria from human milk per day just through the milk. What's interesting also is that a lot of the microbiome in the baby's gut, it really reflects also the microbiome in the mother's breast, and it seems like there's a strong correlation between the mother's microbiome in the breast and the risk of mastitis. So there's really a symbiosis there as well. And again, there's a lifelong effect in the microbiome. how do the bacteria get there? So it seems like there are some dendritic cells that get the bacteria from the maternal gut. They keep this bacteria alive, and they take it to the breast via the lymphatic system, where this bacteria sort of stays there for a few days, and then it's secreted through the breast milk and goes to the baby and colonizes the baby's gut. What's known also is there's a window of opportunity for imprinting in early life, in that really this baby, the newborn, there's this window when it really wants to learn about the immune system, and really the microbiome of the fetus, as I said, it really will reflect what happens for the rest of his life for this child. It seems like by about 3 years of age, the microbiome is very similar to whatever it's going to be for this person in their adult life. Yeah, we talked about that. And a lot of what determines the microbiome, it's not just the bacteria that's transmitted to the child, but there's more and more role of the human milk oligosaccharides. So what are they? And these are something that you're gonna, you maybe hear more and more about it. So the human milk oligosaccharides, they really have a, cool function as well. First of all, they're prebiotics, so they help the good bacteria survive and grow. They promote growth of the good bacteria. They, on the other hand, they are probiotics. They modulate and decrease the growth of bad bacteria. So they have anti-aggressive, antimicrobial properties. They interact with the cell side. They also have an immunomodulatory effect, and they really make it a more balanced immune response to T1 and T2. They also affect directly in terms of necrophilic adhesion and migration and all of this. And what's cool as well, it really seems like they're really important for brain development. That we're going to talk about how the effect of breastfeeding in IQ and brain development. It really seems like it's through the human milk oligosaccharides as well. What's interesting is that it's the human milk oligosaccharides seem to help not just the babies, but the mothers as well. And it really seems to modulate part of the mother's mammary gland microbiome that's protective against mastitis that we talked about. What's interesting is that it seems like you can find some HMOs in the mother's urine right before labor and delivery. And it really seems that protects the mother against UTI during this process as well. All right, so human milk is important, and does it really matter if we, supplement or give a little bit of human milk and, something else? So we'll see. We'll talk about it. So we're talking about microbiome and flora. If you look at the flora of the breastfed infant, really most of it is lactobacillus and bifidobacteria. What's interesting about them is that they really make an acidic environment in the baby's gut. So the pH is pretty low. The low pH really limits the growth of other pathogenic bacteria, such as E. coli, Shigella, Salmonella, and other bad stuff. The babies for formula fed, they have a much higher pH that actually will encourage the growth of the pathogenic bacteria. And what's interesting is that even if you give just one formula, you're going to change this environment. In 24 hours, you change this, and it's really hard to reverse it. It takes several weeks to reverse this. So just one bottle really matters. After just one bottle, you change the microbiome, and the changes occur within 24 hours. That's what we just talked about. A lot of what I'm going to talk about is more about the benefits of breastfeeding, and some global health data. And I want to acknowledge Dr. Cesar Victoria. He's actually from Brazil, and he just this week received the Canadian Gardner Global Health Award He was for his contribution in the health of the mother and baby, and essentially the impact of exclusive breastfeeding. He was the one who was the first person who to recognize that the exclusive breastfeeding prevents infant mortality. He also was the person who leads the WHO growth curve. He also leads a lot of the efforts towards breastfeeding by the UNICEF and WHO. He also was instrumental in the concept of the 1,000 days. That's from conception until 2 years of life, and how this 1,000 days really have a fundamental influence in this baby's future and life. And more recently, he is the one who showed the benefits of breastfeeding in adulting challenges. I actually had the pleasure to meet him. But anyway, so this was actually his first study in the 80s. Then when he looked for the evidence of protection of breastfeeding in infant death by diarrhea in Brazil. So he really noticed that the babies who were fed formula or cow's milk, they had their odds ratio for mortality for diarrhea was 14 versus, breastfeeding was the control. I mean, and if you have a mixed feeding, some protection, but increased risk. And each baby feed with fluids, anything else but breast milk, increased the risk of diarrhea death by 70%. So this was the first study sort of showing that breastfeeding really seemed to matter. He just led a recent review in the Lancet about breastfeeding, so it was published in January 2016, and talks about all essentially the risk of breastfeeding benefits of risk of formula feeding benefits of breastfeeding. And he really showed that breastfeeding, he did a lot of meta-analysis on the published studies as well. So it's really a combined analysis of the recent literature. So clearly there is an effect in decreasing mortality, decreasing infection, decreasing risk of NAC, decreased SIDS, decreased malignancy, malocclusion, and it actually seems like breastfed babies have a better response to vaccine as well, which is really important, especially even in this country now. It's something that's important. It also has some long-term effects that we're going to briefly talk about both of them. I just briefly want to talk about the preemies because, I mean, this is clearly a population at risk, and as OBGYNs, you will really have to, you have an important role in supporting this mother who really could help support this premature infant. So babies fed exclusive human milk, they have decreased sepsis, decreased NAC, they have less feeding intolerance, they have better growth. They also have a lot less readmissions after hospital discharge. And they have better neurodevelopmental outcomes as well. This was a study done actually here in Baltimore at Sinai, and they looked at if, in terms of cost, if feeding human milk diet for very low birth weight infants was cost effective or not. And clearly they found all the benefits of breastfeeding, and they also found that it was totally cost effective. That the total hospitalization cost was lower by about over $100,000 per infant just by an exclusive human milk diet. And they actually incorporated the cost of donor milk and human milk fortifier. Colostrum is also extremely helpful for the premature baby. I mean, for all the babies, but the colostrum is extremely rich in immunoglobulins, and it really seems like it really helps the immune response of the babies, and clearly the babies at risk even more. So just oral care with colostrum. So if you have a mother who delivered a preemie, I mean, if you really just encourage this mother, express some colostrum, give some colostrum to this baby, you are going to improve the outcome of this baby significantly. If you look at older kids, it was shown that breastfeeding decreases the episodes of diarrhea by 50%, and episodes of respiratory infection by a third. And if you look at hospital admissions, it really prevents about 3/4 of hospital admissions and about half of hospital admissions just by respiratory tract infection, just by breastfeeding. What you want to do is also of course, you look at the immediate short-term benefits of breastfeeding, but you really want to look at long-term. And you want, this infant to grow to become a normal, healthy child, a healthy adult, and then, hopefully a healthy senior. And as we talked a little bit, that, it really, it seems like the early diet and the type of milk received is instrumental in programming what's going to happen later in life. So breastfeeding, I'm not going to go over all of this in detail, but it essentially, reduces the risk of obesity for the child, reduces the risk of diabetes and type 1 and type 2. That's another good question. I mean, is it really just the breast milk or it's breastfeeding per se? So there's some studies that looked at breast milk giving with the bottle. And what's interesting is it does seem that there is a difference. I mean, we also show that for the infant and for the production of antibodies, it's different if you breastfeed or give the breast milk in the bottle, because, the retrograde flow and the interaction that you have between the mother and the child is not going to be the same if the mother pumps and gives it through the bottle. But also the risk of obesity is higher in kids who were fed breast milk in the bottle. It's not as bad as if they're formula fed, but clearly it's different than if they were just exclusively breastfed. There's a strong correlation with malignancy and leukemia. This was in Australia. They followed all the patients who were diagnosed with leukemia for at least 4 years, and they found that any breastfeeding patients had a strong protection for leukemia. And if the babies receive any formula within the first 14 days of life, they had 60% more leukemia than the babies who were exclusively breastfed. If the baby was exclusively breastfed for 6 months, the risk of having leukemia was 80% more than the exclusively breastfed babies. I mean, this is huge. Now, more long-term outcome. There are more and more studies showing that breastfeeding seems to improve your cognitive development, and it seems like this is really through the IQ. There's an average increase in 3 to 4 points in the IQ in babies, in adults who were breastfed as babies. It really seems like there is a structural change in the brain of babies who were breastfed. Question is, does it really make a difference in terms of life, right? Okay, you have your IQ is 3 or 4 points higher, and does it really matter? So this is a study also by Cesar Victoria, and he's been in Brazil for many years, and he has several cohorts of patients, and he follows these patients, and he follows almost 80% of the patients from his first cohort who are now in their 30s to see and compare what happens if they were breastfed, if they're not breastfed, and what happens. So what he found was something fascinating, and this was recently published. He found that the adults who were breastfed as infants, they had higher IQ, and they had higher schooling, and they actually made more money. And the amount of money that they made was actually significant. They made about 1/3 more than the other group. And about 70% of the effect of the adult earning was because of IQ and was because of breastfeeding. We talked about the child, but there are benefits of breastfeeding for the mother as well. How are we in time? There are benefits for the mother as well. We know that there's less postpartum bleeding, child spacing, there's less ovarian cancer, breast cancer, improves postpartum weight, type 2 diabetes, cardiovascular disease, and all of this. And I'm going to talk about some of this, not all of them. It's actually interesting in terms of lactation amenorrhea. It seems like in countries where breastfeeding is prevalent, like Uganda, that they would expect about 50% more births if women were not breastfeeding, just because of the lactation amenorrhea. You guys all know that, mothers need a lot of calories, and that really will help mobilize weight, and this will persist for the rest of the life of the mother. There's more evidence now that breastfeeding is protective against breast cancer for the mother, and that every 12-month increase in breastfeeding seems to give a reduction of 4% of the risk of invasive aggressive breast cancer. And it seems like this protection is even more important in patients who are BRCA1 mutation carriers. Of course, as you guys know even more than I do, that they tend to have the more aggressive type of breast cancer. It's protective against ovarian cancer as well. Just any breastfeeding, any breastfeeding, in average has a 30% reduction, and there is a dose effect as well. The more the mothers breastfeed, the less risk of ovarian cancer she has, or the more protection she has. Type 2 diabetes, this is for the mother, significant decreased risk by just breastfeeding. Again, there's a dose response here. BMI, this is a British long-term follow-up study that, they really have this really long cohort of women that they follow, and they found that women that breastfed had a 1% lower BMI for every 6 months. This is graph here is in the United States, it's not in the UK, but there's a direct correlation with diabetes and cardiovascular disease and BMI. So this is really a public health issue. Depression, it seems like there is a correlation between breastfeeding and depression. However, it seems like maternal depression really makes it harder for breastfeeding and not the other way around. But more studies really need to be done in terms of breastfeeding. Child abuse, this is something that we don't hear that much, but I think it's a very interesting study. Again, another, I would say, public health issue as well. There's another large prospective study that they looked at child abuse or neglect perpetuated by mothers and the effect of breastfeeding that breastfeeding could have. And after correcting for potential confounders, they found that just the fact of any breastfeeding, if the mother didn't breastfeed, this child had a 160% increase in child abuse compared to the babies who were breastfed. And we all know that child abuse is it really goes throughout all levels of society. There are risk factors, but it's something that we see everywhere, anywhere. If you look at, so we talked a lot about morbidity. When we look at mortality, essentially mortality, if you look at mortality, of course, it's more significant in low and middle income countries, which in this graphic, in this map, is showed as, low income countries in red, then low middle income countries in orange, and upper middle in yellow. If the patients were exclusively breastfed, so never breastfeeding versus exclusive breastfeeding, patients who were not breastfed compared to exclusively breastfed, they had 8 times mortality compared to babies who were breastfed. This means that the babies who were breastfed had a 12% chance of death compared to the babies who were not breastfed. I'll show you. This is within the first 5 years of life. This is infant mortality, yeah, first 5 years of age. And of course, this is exclusive breastfeeding. Any breastfeeding also decreases it protects the child in terms of mortality, and it phases out a little bit as the child becomes a little older. So this answers your question in terms of what they lost. So this is talking about infant mortality, children less than 5 years of age. So if breastfeeding was scaled up to ideal levels, which is 95% in babies less than a month and 90% in exclusivity for 6 months, every year in the world you'd save 800,000 child deaths from children less than 5 years of age, and you'd save 20,000 women from deaths of breast cancer. In terms of economic impact. This is data from the United States. And we know that, okay, you know, in this, here we're talking about scaling up breastfeeding to 90%, which of course would be ideal, but we are so far from that. But we can say, you know, we just increase a little bit, just increase by 10% the exclusivity rate in the United States, which nowadays is you know, almost 20%. So if we go from 20% to 30%, and if you continue breastfeeding for at least 1 or 2 years, which again currently are essentially 25%, you would save $312 million in the United States a year just from pediatric illnesses. We're not talking about total cost, total savings. We're not even talking about environmental costs of breastfeeding. Clearly, you know, breastfeeding is a natural and renewable food that is environmentally safe. It's delivered to the consumer without pollution and no necessary packaging or waste. Whether breast milk substitutes, you know, it requires energy for manufacturing, materials for packaging. There's, you know, fuel for transport and distribution, and of course, you know, water, fuel, cleaning agents, and everything else for daily preparation and use. So what can we do about it? You know, how can we help? I think, I hope I've shown you some interesting data that, you know, really, this is something that we should care about. It's not insignificant. And I think we really need to see breastfeeding as a public health issue. It's not really a personal choice anymore. It really should be seen as, you know, as vaccine, as cancer prevention, as smoke cessation. It is a public health issue. And unfortunately, what happened over the, you know, the past several years is that we really set up these women for failure. Breastfeeding is known as natural, became invisible. We were just talking recently that, you know, it's hard to breastfeed in public, even though it's the law that people are allowed to breastfeed in public. But we really, it became a little marginalized. And, you know, by saying that's natural, it really makes people assume that it's easy. And it's not always easy. I think it's much easier if you have a society where everybody supports you, where it's very easy to ask for help. But in a society where people don't know about breastfeeding, the mothers didn't breastfeed, these women really need help. And it's really important to take the burden off the mothers, and we really need to help them. There's more and more data that more than 90% of the women come to the hospital and they want to breastfeed. And then yes, our exclusivity rate is really low when they leave the hospital and at 6 months or, you know, a year that they show. So what can we do about it? The problem is that this is, you know, what's happening is that then if we push too much and we don't really support this mother, then, you know, then all this, you know, they're starting, well, these are lactivists, and there's a lot of, you know, push against breastfeeding. And so we really have to find a balance. I mean, clearly, you know, formula companies have a strong interest in demoting breastfeeding. And, you know, they are sneaky. They, you know, with the formula bags, it really has data showing that mothers who receive the formula bags, they have less exclusivity rates. I mean, I know that, you know, the bags now have been banned in the state of Maryland, but it's still given in several states in the United States. But now they, you know, they become even more trickier. So they are supposed now to answer questions about breastfeeding. And they're giving all these supplements for breastfeeding, for breastfed babies. I mean, this is all the same thing. Really what's important is, you know, we've talked about, is really providing an environment that supports the mother. It really is a global health issue. It's important to have policy, it's important to have maternity leave, it's really important to provide workspace accommodation for the lactating mother. It's known that it's beneficial for the employers as well, that as mothers, they have less absentee from work because their kids are healthier. Again, public health issue. You know, it's more a local level. I'm sure you're all aware about baby friendly and the 10 steps that, you know, I'm very happy to hear the University of Maryland is going through. And, you know, essentially what it is it encourages, you know, best practices in the hospital to encourage exclusive breastfeeding for the mother. What's interesting is what it's not as well, because it's not, the idea of baby friendly is not to put guilt in the mother. It's not to blame this mother. It's really also to respect the mother who says, well, I don't want to breastfeed, and still support her. And worldwide, there are more than 15,000 facilities that are baby-friendly. In the United States, that's over 400 hospitals that are baby-friendly. And in Maryland now, there are at least 7 hospitals or more that are working towards baby-friendly. So I think we are doing some progress. I'm not going to go over the 10 steps of baby-friendly, I think, but I'm going to show you that it does make a difference. So even if you have just 6 steps of the 10 steps for baby friendly, the percent of mothers who stop breastfeeding really decrease by each step that you implement. You guys as OBGYNs, you have a really window when you can reach the mother before the baby is born. And oftentimes even before they are pregnant. And we know that the majority of women really decide how they're going to feed their baby in the first trimester of pregnancy. So there are several reasons why they decide to breastfeed. There's personal perception, there's exposure to breastfeeding. We talked about that if they know people who breastfeed, it becomes more they won't even think too much about it. Their breastfeeding knowledge and of course lifestyle and everything else. But again, I think this is really important that most people really decide way before the baby is born how they're going to feed their babies, and you really have an instrumental role there. I think the other thing that we have to think about supporting a mother when they're breastfeeding is. A lot of times in our population we work with African American mothers. It's really, you have to look at breastfeeding with their sum of experiences. I mean, this is a picture of a wet nurse, feeding a white baby. And a lot of times these women really, culturally, they really don't want to breastfeed because they were made to breastfeed. They were not breastfeeding their own babies, but they had to breastfeed the white babies. And you really have to understand to really help this population. Oh, this didn't come up. Okay. The other thing is in the office, what can we do? Create a breastfeeding friendly office. So no formula ads, no samples in the office. Have supportive posters, magazines. Have an educated staff who really has a consistent message. That's important because if they hear somebody is supporting breastfeeding, then on the other, the nurse is not supportive, or the physician is not supportive. They really, you're sending mixed messages. Telephone triage, protocols, and that's an important thing also. And this is support of that and the family for breastfeeding. And know how to help this mother, not just in your office, but when they go outside your office, how can they find support? Where can they find peer counseling? Again, ask early and ask often. It really takes 1 minute, or maybe even less. Just ask, what do you know about breastfeeding? Have you noticed your breasts are changing? That's in preparation for breastfeeding. You have a window in every visit when the mother comes to talk about breastfeeding, to encourage her to breastfeed. Now, briefly, I want to talk about when breastfeeding is not going well. And, I think sometimes we really push too much breastfeeding, and we really need to recognize when it's not working. And, with every single organ system in our body, sometimes it just doesn't work. And it doesn't work 100%. There is about 1 to 5% of breastfeeding failure, and we need to recognize that. And we need to support this baby and this mother. I think we need to see formula as antibiotics. It can be life-saving for the mother who has lactation failure, but it really needs to be given judicially because it really has a lot of side effects as well. Sorry, in terms of time. All right, some maternal risk factors. I'm not going to go a lot in details here in fashion of time, in favor of time. First-time mothers. Mothers who had trouble conceiving, mothers who have a difficult labor, postpartum complication, didn't have breast changes during pregnancy, obese mothers, some of the other risk factors for the baby. Important, when it's premature baby, multiple, baby with any medical problem, babies that are separated from their mothers, all of this are risk factors. Again, the important thing is that we recognize this. As healthcare professionals, we need to recognize it. We need to support the baby. We need to weigh this baby. That's really the best way to recognize lactation failure in the baby. And breastfeeding is really a confidence game. It's really a balance between reassurance but adequate infant intake, making sure that this baby is okay. We as physicians, we don't do really well in terms of breastfeeding. We unfortunately breastfeed less than the general population. We initiate, so this is data from the National Immunization Survey. So this is the black bar is the general population. And these are 3 different studies looking at physician mothers' breastfeeding behaviors or what happened. So you can see that physician mothers really, they know that breastfeeding is great. So they all initiate breastfeeding way more than the general population. But you can see that at 6 months, most of them have lower breastfeeding rates than the general population, and clearly at 12 months, way lower. I mean, these are the single digits. We also know that there's strong prediction between the physician's mother's breastfeeding experience and their advocacy towards breastfeeding. So if you go back here, if the physician's mother, if you're not supporting the physician's breastfeeding in the workplace, not in the workplace, but while a lot of the problems is when they go back to work. It's going to be, they're not going to advocate so much for their patients. And so we really need to develop also workplace strategies and programs to promote breastfeeding. One of the other resources that I want you to know, if you don't know about, is LACMED. A lot of people just say, well, stop breastfeeding because the mother's taking medication. So LACMED is it's a free app you can just download on your phone. It's from the NIH, and it's great resources for drugs and safety of drugs during breastfeeding. Another really easy resource for you guys. I really encourage you to watch this movie if you haven't, by Jane Morton. She's a pediatrician in Stanford, and she just made this. She has several really educational movies, some about hand expression, and she just made one in the breastfeeding the first hour. And I really encourage. It's about 15 minutes or even less than that. I really encourage you to take a look at that. It's really very helpful. Through the Department of Health in Maryland and the Maryland Breastfeeding Coalition, we just recorded 5 seminars by outstanding physicians in breastfeeding medicine. These are all free, and they provide CME. So, I encourage you to try to watch them as well. And this is the link where you can find it. If you go to the Maryland Breastfeeding Coalition website, you can find the link for that as well. Some other resources that I want you to be aware of. The ACOG breastfeeding toolkit is a good start. At the same time, the AP, there's a section on breastfeeding as well. I don't know if you are all aware about the Academy of Breastfeeding Medicine. So this is an academy that is just by physicians that are interested in breastfeeding. There is about 300, 400 physicians in the world in the Academy of Breastfeeding Medicine, and there are several protocols online at the ABM website. They are free, and they are all research-based. They talk about supplementing. They talk about how to encourage breastfeeding in the office, how to take care of the newborn with jaundice, and it's really a great resource. We talk about the Maryland Breastfeeding Coalition. And I'll just read some of the others. These are some books. I want to finish the talk with a quote by a pediatrician in the 80s. And in all mammalian species, the reproductive cycle comprises both pregnancy and breastfeeding. And in the absence of the latter, none of the species, man included, could have survived. And I'm opening up for questions.
start with, I hope you can make your slides available to the audience so we can take advantage of the bibliography. I think that all of us have benefited this morning from the, I think, the methodical scientific approach you've illustrated. And, I think if I'm honest about my colleagues, most of them are kind of, well, it couldn't hurt that much. You just have a bottle, you can have a nap, your baby will sleep, you'll sleep. On a day-to-day basis, how do you approach our typical patients who, after 2 days of trying really hard, finally believe that they are exhausted and the baby's not doing well and the whole breastfeeding experience is negative, and out of pity or comfort or some kind of compassion, our nurses or the grandmother or somebody stick the bottle in the baby, and all of a sudden everything is fine again?
Yeah, it's an interesting question. It's a good problem, and I think a lot of times, if we know that 80 to 90% of the mothers come to the hospital with the intention of breastfeeding, so they want to do it. I think if you explain to them a little bit about how breastfeeding works, supply and demand, and you also, a lot of times they will try it. Again, it shouldn't be the blame on the mother. You really need to help support this mother, and you have to support the mother, but you also have to talk to the grandmother, to the father, and they need to support the mother, and they have to help this mother. Essentially, what needs to happen after this mother has a baby, the whole environment needs to support her so she can stay with the baby. It's not, give me the baby, I'll take care of the baby while you sleep. It's like, okay, you sleep while I take care of the baby a little bit, but once the baby wakes up, I'll, give the baby to you, you feed the baby, and I'll take care of the baby. You go back to sleep. But there's so many other things that they can do besides just giving the bottle and letting the mom sleep. Right? They can change the diaper. There's a lot of things. And I think a lot of it is really understanding how this whole thing works. And there's actually data also showing that once you give the bottle, usually the babies are completely weaned by 4 to 6 weeks, independent of when you introduce this bottle. If you introduce the bottle early, in the first month of life, in about 6 weeks, the baby's formula fed completely. If you introduce the bottle at about 7 months of age, the baby is going to be formula fed when he's 9 months of age. It's about a month, a little bit over a month, and then the baby's exclusively formula fed. So the one bottle makes a big difference, not just in physiology that we showed, but it's also in what's going to happen with this child later on.
Slippery slope.
It's a slippery slope.
I think we've kind of overlapped because of the importance with our next speakers. So I'll invite Dr. Shimon back to speak with us some more, and maybe in a seminar format, so we can have a lot more engagement or questions and so on. And thank you very much.
That'd be great. And I'm a pediatrician and a pediatric intensivist. Really far from breastfeeding in a way, but there's a lot of things that we can do even in the picture with breastfeeding. So if you have any questions, just come find me. And I think it became pretty obvious. I'm pretty passionate about this. And I'm more than happy to give you some resources or help you with whatever I can do.
Thank you very much.
Thank you.